House File 4011. And this is going to Health, Finance, and Policy. If you want to make the motion.
I would like to move my bill 4011 to be before the committee.
And we re-refer to Health, Finances, and Policy.
Yes, please.
Bill's before us. If you want to explain your bill.
I do. So this is probably going to be the easiest bill that you'll ever vote on. This was something that I'd bet most of us are not aware of. But once you become aware, it is a horror. So we are talking about surgical smoke. And this is what happens when you use anything that is like lasers or electrosurgical pencils. These are things that, you might have used on you if you have an appendectomy, cesarean section births. Anything that requires those tools gives off smoke, obviously, sometimes called surgical plume. And so what that does for surgical nurses and for the patients, they can breathe in up to, I want to say 150, hazardous chemicals. You can breathe in, yes, gross. You can breathe in the HPV virus, portions of human flesh. This is like a really bad movie, except it's real. And so for the nurses that might breathe this in, it can be like smoking, like 20 to 30 cigarettes a day. So nearly a pack and a half of cigarettes a day over, all the surgeries that they attend and over the course of their lifetime. So what this bill does is require surgical smoke evacuation to be mandated in all of the operating rooms so that we can protect our nurses and also protect our patients. They're a little bit less risk, the patient is, but I mean, if we're talking mothers who are having cesarean section, yes, and they're breathing in that smoke, as well as the brand new baby is also breathing that in. And so if we aren't horrified by what it's doing to our nurses, I hope we're horrified about the effects on brand new infants. So that is an overview of what we're dealing with. Sorry, we're dealing with this after lunch. And I do have a couple of testifiers, Mr. Chair.
I have two testifiers on the list. First one is Ann Jones. And if you want to come up to the dais, if you want to have a seat, and then identify yourself for the tape, and then proceed with your testimony.
Chair Nelson and members of the committee, my name is Ann Jones. I'm here to express my support for House File 4011, a bill that would require use of surgical smoke evacuation systems in hospitals and ambulatory surgery centers. I am a retired RN who practiced nursing for over 45 years, 25 of those years in operating rooms as a staff nurse, a clinical educator, and a manager. The two most important developments in surgery other than anesthesia were infection prevention and the ability to reduce or prevent serious blood loss via use of electrical current, which creates heat and thus smoke. During larger open procedures, the entire team is working in a literal cloud of smoke. Surgical masks are not designed to prevent breathing it in, and the most efficient solution is smoke evacuation, taking the smoke away from the field. Surgical smoke is a health and safety hazard that affects operating room nurses, surgical technicians, surgeons, anesthesia providers, and patients, and anyone else present or passing through the room. The adverse health effects of surgical smoke have been known for decades. I've lost count of the number of classes and workshops I attended on the hazards of surgical smoke and ways to prevent exposure. Most facilities have purchased smoke evacuation equipment and all of the associated tools, cautery tips, filters that go with it, but use is not mandatory and compliance remains very inconsistent. I can tell you that a lot of expensive equipment is sitting around unused in hospitals and surgery centers. So, and even though the equipment has gotten smaller and quieter over time, and the handheld devices are more comfortable, Resistance among surgeons remains an obstacle. Given the hierarchy that still exists in healthcare, especially in operating rooms, nursing staff tend to defer to surgeon preferences, even when facility policy exists. Staff members really can't choose whether or not to work in those rooms if they are experiencing any health effects. They are assigned. The legislation that you're considering today will make it easier for those of us in operating rooms to do the right thing rather than leaving it up to nursing staff to negotiate with individual surgeons or deciding on their own not to comply. In my experience, safety is best assured by having standardized routines and supported in law when needed. Please vote yes on House File 4011 to protect patients and healthcare workers in Minnesota. Thank you.
Thank you for your testimony. The next person I have on my list is John Zender. And welcome to the committee. Please state your name for the record, and then you can proceed with your testimony.
Chair Nelson and members of the committee, my name is John Zender, and I'm here to express my support for HF 4011, a bill to require surgical smoke evacuation policy for hospitals and ambulatory surgery centers. Thank you, Representative Berg, for sponsoring this bill. I am a professional circulating nurse, and I'm from Crosby, Minnesota. I've been in practice in nursing for 25 years in the great state of Minnesota, and I've worked in healthcare for 35 years. I hold 2 bachelor's degrees from Minnesota State Mankato, a nursing degree from Century College in White Bear Lake, and a master's degree in nursing from Capella University in Minneapolis. I currently work in surgery at the University of Minnesota. I'm also a retired firefighter with 20 years of service. As a firefighter, smoke is an obvious risk of the job, but every big fire I walked into, I was never worried about exposure to fire or smoke. Why? My equipment protected me. Smoke inhalation was never a worry because I carried an air tank that delivered clean, filtered air. Surgical smoke, as they said before, contains 150 hazardous chemicals. Let's go over some of those chemicals, shall we? Carcinogenic and mutagenic cells, toxic gases and vapors such as benzene, hydrogen cyanide, formaldehyde, bioaerosols, dead and live cells, viruses, and blood fragments. In a house fire, whoops, I went too far, I'm sorry. In a house fire, many of these, believe it or not, many of these hazardous chemicals are similar. But again, I carried an air tank and wore a mask that delivered clean filter air. Thankfully, in my 20 years as a firefighter, I did not have to experience smoke from burning flesh. Only in the operating room, where we're all expected to be clean and sterile, do I experience burning flesh smoke. In my career as a circulating nurse, I'm often surrounded by smoke with little or no protection. OSHA, on respiratory protection, states, surgical masks used to prevent contamination of the patient are not certified for respiratory protection for medical employees. The Minnesota Clean Air Indoor Air Act, I believe it's also known as the Freedom to Breathe Act, protects employees and the public from health hazards of secondhand smoke. The provisions went into effect in October of 2007. Yet in the operating room, surgical smoke is not protected by that Clean Indoor Air Act. For me, the current generation has a duty to the next generation to pass on our knowledge of what we know and have learned that make our profession better and safer for them. My son Connor is currently in nursing school up at Bemidji State. He has expressed his intent, believe it or not, to enter the profession of circulating nursing. I'm proud he wants to join this profession that I love. But I want Connor and his fellow nursing students to work in operating rooms that are free from harmful surgical smoke. For me, this bill is not just the right thing to do, it's personal. So please vote yes on HF 4011 because it's the right thing to do. Thank you.
Thank you for your testimony. Members, any questions? Seeing none, Representative Myers,
Thank you, Chair. Thank you, Representative Berg. You know, this one is near and dear to me. My wife is a nurse. She's taken a few years off because we've, had kids, and actually texting her here as we talk about this bill. I wanted to ask in regards to the surgical smoke defined. Do you feel that definition covers everything, including potential for, future technologies under the definition there?
Representative Berg.
Thank you, Mr. Chair, and for the question, Representative Myers. I do have folks here that can come up and answer the question.
Please come to the table and, again, identify yourself for the tape, and then you can answer the question.
Thank you, Chair Nelson, members of the committee. My name is Jennifer Pennock. I work for the National Association representing the operating room nurses. So your question was regarding the definition of the smoke evacuation equipment or the surgical smoke itself?
Representative Myers.
Thank you. Yeah, in regards to like energy generating devices, and it talks about including, I'm just wondering, do we feel like this is an all-inclusive way that it can be produced through these devices, and is this going to potentially cover any future uses as technologies change?
Sure.
Ms. Pennock.
Mr. Chair, thank you for the question. Our National Association writes a number of guidelines related to surgical procedure, surgical health, and we have a guideline on evacuation of surgical smoke. So in developing this policy language, we were able to consult with our guideline author on evacuation of surgical smoke. I'm not a nurse, so of course I'm not an expert in this area. And our experts on staff were able to say that they believe that it's inclusive of any potential future technologies that we have not foreseen.
Representative Myers.
Thank you for that. That's all I had.
Any further questions? Representative McDonald.
Chair, thank you. Question on the doctors and how do they feel about this? I had heard that they are reluctant for some reason, so I'm just curious as to why that would be.
Sure.
Ms. Pennock.
Mr. Chair. So opinions vary and surgeon preference varies. So some surgeons are early adopters. They've been using the equipment for decades back when it was bulky and cumbersome and loud. Some surgeons express concern about use of equipment and don't like it and don't want to use the equipment. There are many options for evacuation of surgical smoke, and it doesn't have to be that handheld device that the surgeon is using. So the hospital or ASC can determine that someone else will stand there with equipment that would evacuate smoke so that it would protect the health and safety of the occupants of the room and not mess with surgeon preference or how they feel they can do their job. We have not had official opposition from an association of surgeons or an association of physicians.
Representative McDonald.
Thank you, Mr. Chair. So if I understood correctly, that perhaps this would require yet another person in the surgery room overseeing that, if the doctor didn't want to hold both that particular device. Is that correct?
Mr. Chair.
Ms. Pennock.
Yes and no. It would really depend on how the facility is staffing that operating room, from the outset. So it's my understanding that, sometimes say a medical resident might be the one stepping in anyway as they're learning, right? So it's not necessarily an additional staff member or some of the other staff in the room. It really depends, and what we've done when we've crafted the legislation, asking that facilities adopt and implement these policies, we've done that so that the facilities can have the flexibility to implement what works best in their specific facility.
And Representative McDonald, that's why we're sending it to Health Finance.
Very good. Thank you, Mr. Chair.
Representative Schultz.
Thank you, Mr. Chair and Representative Berg. It's fun to learn about a new issue and concern, and I certainly do appreciate that. I feel for the everybody who works in these facilities and this concern. So I just wanted to kind of talk about enforcement to this, and just kind of hear from you a little bit about how you see the enforcement of this bill taking place across Minnesota.
Representative Berg.
Thank you, Mr. Chair, and thank you, Representative Schultz. So it's my understanding that this would fall under OSHA from the Department of Labor. And so it is fortunate that we passed a labor bill last session that gave us 5 more OSHA investigators. And so what I want to say about this is when you have a safety-sensitive job, and by no means am I comparing being a flight attendant to a surgical nurse. However, there are reasons why we have policies, rules we have to follow, procedures we have to follow consistently across every airline, every base, because it matters. Those seconds matter. And so when you're in an environment like this and you are literally saving human lives, improving human lives, the consistency that's needed across every facility just makes it easier for each facility to run well, to protect patients and nurses and whoever's in the room, whether it be surgeons or interns. And so I think that's important to say as we're talking about enforcement, because that is a necessary piece of this. And so that was just a long explanation for your very simple question.
Representative Schultz.
Thank you, Mr. Chair and Representative Berg. Do most healthcare facilities, do they already have this equipment and it's just not in use, or are we anticipating that this is going to be an additional cost to them in this calendar year?
Representative Berg.
Thank you, Mr. Chair, and thank you, Representative Schultz. Yes, most of the facilities already have this equipment. As our testifiers were talking about, some surgeons choose not to use it. The original ones, as I believe Jennifer said, were a bit cumbersome, and surgeons didn't want to have that extra device to hold in their hands and have to be responsible for. However, yes, by and large, most facilities already have the equipment. It is getting the surgeons to use them and the enforcement mechanism to ensure that they are.
Representative Schultz.
Thank you, Mr. Chair and Representative Berg. Can you help us out by kind of maybe outlining what the cost of this equipment is for those who don't have this equipment already? And the reason for my question is to hopefully eliminate the barriers to these healthcare facilities obtaining them. I represent a rural community. Access to rural healthcare is, challenging at times, and I certainly wouldn't want to see additional burdens on struggling healthcare facilities and the access that it provides, especially for rural residents.
Representative Berg.
Thank you, Mr. Chair, and thank you, Representative Schultz. By and large, this is not going to create an undue burden, and we did actually in our discussion focus on those smaller rural hospitals and facilities. I am going to let my testifier give a better answer, but I just want you to know that that was a consideration in this legislation.
Ms. Bennett.
Mr. Chair, and thank you for the question. So in terms of the costs of the equipment, costs vary, much like everything in U.S. healthcare, right? So there's oftentimes you might use a good comparison of the electrosurgical pencil that has the smoke evacuation and that doesn't. And there might be a difference in that individual piece of equipment. I have heard anywhere from $3 to $20 per. The equipment that evacuates the smoke is attached to a smoke evacuator system that filters the smoke. So there's the suction tube, it filters the smoke, it has an ULPA filter. It kind of reminds me of first generation VCR, if you're thinking about the box. It's mobile, it can move from OR to OR. Those can be thousands of dollars. Often, when you are negotiating and working on your capital budgets and identifying the device company that you're going to go with, you can negotiate, say, that box free for the guaranteed purchase of so many of those pencils, or vice versa. So it really just depends what the company, what you've negotiated in terms of your purchase and your costs. For the rural facilities, there will be a lower volume of surgeries than there would be in an urban facility, so that certainly helps. And we did, as Representative Berg mentioned, the majority of facilities in Minnesota have the equipment. AORN surveyed our members ahead of working on this legislation, and 95% of our respondents, which included rural, urban, outpatient, inpatient, and ambulatory surgery center, 95% indicated that their facility had the equipment already.
Representative Schultz?
Thank you, Mr. Chair. Following up on your question and then talking about, how we navigate, especially those smaller systems, this may be a little bit of a rhetorical question, and I don't mean to belabor the point, but just generally, do we feel like a mandate is the best approach to this challenge to get the best compliance and the best results for all healthcare facilities?
Representative Berg?
Thank you, Mr. Chair, and thank you, Representative Schultz. I know you love talking about mandates, so happy to oblige. So one thing I want to mention, which is why it's fantastic to have experts in the room, is actually DLI has grants available for hospitals and the other facilities that might want to invest in this or upgrade. And so that's fantastic in terms of taking the burden off of some of the facilities. In terms of mandates, if I were you, I think I would look at it more as what is it that we can do as a state in partnership with our experts to help protect our people, right? We ran for office. We're here to do good things for Minnesotans. Let's do that.
Representative Jordan?
Thank
And
you,
we need to move along on this because we got other bills to get to, and so Representative Jordan.
Thank you, Mr. Chair. I just wanted to point out that if you look at the fiscal note on page 2 under assumptions, it outlines in quite detail that how MNOSHA plans on doing the compliance with this bill and outlines quite a bit. It also says that they, to read from the fiscal note, MNOSHA has reached out to several different healthcare facilities within the cities as well as northern and central Minnesota. And they've all responded that each one currently has a smoke evacuation system, with many employers already using this technology, and then talks about how, and much of what Representative Berg said. So, you can take it from Representative Berg, or you can read it in the fiscal note that details all the costs and assumptions there. So, I think it's just a good idea for us to look at the material, because often our questions can be found there.
Thank you, Representative Jordan. Representative Kozlowski. Representative Myers.
Thank you, Chair. Representative Berg, I just had a question in regards to, if you can answer or somebody else can, subsection 2 talking about policies that prevent exposure, and then the specific word requiring. I'm just wondering, in emergency situations at a hospital, I'm just trying to see if this is covering everything. Are there those times that you can't always be prepared and it may happen, and potentially what's the potential liability of that for a hospital or the people that are impacted by this?
Representative Berg.
Thank you, Mr. Chair. I am going to let one of my testifiers answer that so that we can have the most correct and responsible answer. Thank you, Representative Myers.
Ms. Penick.
Mr. Chair, and thank you for the question. So even in an emergency procedure, there's a plan in place. The facility has a plan in place how these operations will be handled. So, and if the equipment is available in the room, and that is the equipment you use, then that is how the surgery would be performed, if that makes sense.
Representative Myers.
Yeah, thank you. I just want to make sure that, I'm not a doctor. I watch a lot of shows on TV that maybe, put some crazy situations out there. I just want to make sure that if there are situations where, again, somebody comes in and you got to do something quick and it's not prepared, I understand with an operation, a surgical plan in place, but I'm assuming there's times where there's not. So I just want to make sure that, there is maybe that little room in case something like that happens, that maybe, you're not going to get a huge fine on something. Just something to consider.
Ms. Penick, and I'm reading it, it says they should adopt and implement policies that could probably be part of their adopting and implementing the policies is for those emergencies that you're talking about, have something in their policy that deals with that. Ms. Pennick.
Mr. Chair, you took the answer right out of my mouth, so thank you.
Scary. Any further questions? If not, all those in favor of Representative Berg, if you want to quick wrap up and then renew your motion.
Absolutely. So I love Representative Jordan pointing out the obvious. We all have all sorts of papers, so Representative Schultz, you do not have to take my word on any of this. Go ahead and study your packet. I think that we can agree that this is kind of one of those duh moments where we just want to protect the folks that are in the most vulnerable situation. You will see on one of your handouts the number of states that have already passed policy like this. So it is clearly a movement to make sure that our people are safe and well cared for, as well as the people that take care of us. And so it's the AORN handout, and you can see at the very bottom the number of states that have implemented this. So with all of that being said, all of the great answers from our experts and the really sort of gross and nasty details that we all got to learn about today, I renew my motion to re-refer House File 4011 to Health Policy and Finance Committee.
The motion's been to move House File 4011 to Health and Finance and Policy. All in favor, say aye. Aye. Opposed? The ayes have it. The bill's referred.